one guiding principle for me when approaching diagnosing orthopedic disorders is that it's one problem until it's not. Or in other words, it's one problem versus many. And here, just like in almost any conversation about orthopedics, it's relevant to bifurcate injuries into those that are significant traumas and those that are not traumatic. Because like in any conversation, there's a big difference when addressing via diagnosing and treating those two cohorts of types of patients. So for the acute trauma, significant trauma to the person, we can think that it's more likely that there's more than one problem. I'm still thinking though that it's one, but maybe very quickly within a minute or two, you're realizing not only did they break their scapula in the car accident, but they also broke their humerus and severed a nerve, for example. Or when the patient had a major ankle injury in an athletic event, not only did he rupture or tear a ligament, but he also injured a tendon. Those things do happen, but the majority of patients are not suffering those traumatic injuries, even though I think people kind of think of orthopedics as that former category. They're not. Most people are having repetitive kind of use injuries. And maybe you would, if you want to invoke the word trauma, you could call it repetitive micro trauma to a structure in the body. But those are most people. There was not significant major trauma. There might have been a specific event, but it was not a major trauma to the body. So the reason I think it's so important to have that kind of guiding principle of it's one problem until it's not is because you really need to approach diagnosing and treating with an algorithm so that you don't get confused. At its core, treatment or diagnosing with a clinician should be an informed investigation where every visit is kind of like an evaluation to figure out what's going on. But American mainstream medicine teaches you, especially in orthopedics, that you go into the clinician on day one and boom, you have your diagnosis on day one and you're off to the races with treatment. And I, of course, really reject that idea. Maybe in the acute significant trauma patients or the people who caught a contagious infection, that paradigm exists and holds true. But for the majority of patients, it doesn't. You need time to figure out how the body is behaving, what are the significant factors in that person's life to kind of really get a good program in terms of treatment. For example, think of diabetes. In mainstream American medicine, you get your blood glucose tested, you get your HbA1c tested. Day one, you have diabetes. We can prescribe medicine, treatment, we're off to the races. Whereas if you think about how to reverse diabetes, well, yes, you may diagnose it easily with blood labs because those types of disorders can be easily diagnosed with blood labs. But then you need time to figure out what do we need to change with that patient's life. Is it diet? Is it frequency of eating? Is it getting outside, sun exposure? Is it sleep? Is it stress? What are the things that's dysregulating that person? And it takes investigation to change things over time and see what really naturally brings the body back into homeostasis. And orthopedics, I think, is the same way. You hurt your back. Okay, well, we've ruled out that it's major structural trauma. There was no red flags in the person's history. There was no major trauma. We need time to figure out what we need to change in that person's life. So this principle of it's one problem till it's not, commonly for me relates to it's spinal before it's extremity, because I don't think people get bilateral elbow tendon problems at the same time. It's more likely one problem is more likely in the spine, or it's more likely that it's one problem and it's non-musculoskeletal in origin. Sometimes there are two problems, of course. I did a video on a gentleman where 80 to 90% of his shoulder complaints were resolved with repeated movements of the neck. And then what remained after moving the neck was a bit of capsular tightness, likely because it was restricted mildly in about 3 planes of motion. And therefore the treatment changed from neck repeated movements to stretching the shoulder joint in 3 different directions on a regular basis. But the reason for my principle is because in those cases, let's take his case, if I was still moving his neck and moving his shoulder at the same time, meaning treating both at the same time, and the patient gets worse or better, I can't deduce what was the cause. In some cases, yes, they're very clear, distinct patterns, and we can only attribute change to one specific intervention. But for most people, if his shoulder starts getting worse, I don't know if it's because the stretching's too aggressive or too frequent or in the wrong direction, or because it's now getting inflamed, or I had the wrong neck movement. So that's why I think of it as one problem until it's not. Another example, because people often will say, well, maybe there's a component in the spine and now we've gotten the joint moving better, but I think there's a tendinopathy in the joint. Well, the same messaging applies. If you have sciatic nerve problems, say you have an L4 radiculopathy and the main presentation is plantar flexion weakness and maybe ankle and calf pain, well, say I wanted to treat both at the same time because the patient's really like, I really want to treat my Achilles. It's weak and painful. Whereas my argument would be, I work inside out in the majority of cases, meaning spine out. So I want to fix the spine first. And if anything remains in terms of weakness and or pain at the Achilles, I will broach that topic when we get to it. that's my approach, but say the person really wants to start doing some Achilles stuff. It's the same idea. We can start doing loaded plantar flexion or tendon management, tendon rehab, if you will. And again, if the patient gets worse or better and we're even not moving the spine, I don't know if the person's getting worse because it's too much for the tendon or worse because we're irritating that L4 radiculopathy. So that's why I'm very systematic in kind of having an approach. I don't think you can think about these medical problems, which unfortunately I think as people get unhealthier in this country are becoming more complex and probably more likely to be more than one problem. You have to have some guiding principle or you're just going to get, like I said, you're kind of going to get lost in the weeds and not have the best outcomes. Do I think it takes longer to think of things this way? Absolutely not. Because all those times where you don't have a formula, you are getting setbacks a lot. Whereas if you have a formula, we're going to fix this problem and whatever remains, we're going to go after it then. I think that's a more fruitful way of thinking about these things.